Welcome everybody, and thank you all for joining us today for our National Myeloma Update with highlights from ASH. Today is our first seminar for 2021. I'd like to begin by acknowledging the traditional owners of the land on which we meet today. I would also like to pay my respects to the elders past and present. My name is EJ Furphy, and together with Laura Jones and Rachel McCann, we make up the Victorian Support Nurse team. We are fortunate to have two wonderful speakers here with us today. In session one, Dr. George Grigoriadis will give us a Myeloma 101. Session two, Michael Lowe will present an update from the American Society of Hematology. This is a conference which is held at the end of each year in the States. ASH, as it's more commonly known as, is a very important meeting in the hematology space. Clinicians from around the world submit posters and oral presentations on important and novel research in their specialty field. Over 5,000 abstracts are submitted and 3,000 are accepted through extensive peer review. At the end of each session, the doctors will spend some time answering your questions. If you would like to submit a question to either George or Michael, you can do so by scrolling down on your screen from this live stream. Here you'll see the question form. If due to time constraints we can't get to your questions, we'll endeavour to respond to your questions next week, via email. The seminar will be available to watch again via our website at a later date. You're able to access it by heading to our website and clicking on the seminar link. Please remember to fill in the evaluation form at the completion of the seminar. The evaluation form can be found underneath the question form. Your feedback is valuable, and we want to ensure we are improving and delivering you the best online seminar in the future. So let me introduce George. George is currently employed as the clinical and lab hematologist at Monash Health and the Alfred, and is a senior lecturer at the School of Clinical Science and Monash Health. He is the head of Immunohematology Research Lab in the Centre of Cancer Research at the Hudson Institute of Medical Research, and he was a recipient of the Victorian Cancer Agency Clinical Research Fellowship, undertaking research in understanding blood disorders, and in particular myeloma and myelodysplasia, and translating these findings into important patient outcomes. George is the joint head of the myeloma service at Monash Health, and he's involved in the establishment and implementation of the Cancer Service Plan for the communities of the Bass Coast and South Gippsland. He's passionate about the provision of care to patients close to home. Thank you, George, for joining us today.
Thank you. So, and welcome everybody. It is a little bit strange. I find it difficult to actually be able to present to an audience where I can't actually see them, but anyway, welcome, and I hope you find this useful and enjoyable. Some of you may have heard bits and pieces of this, and if you have, hopefully this consolidates your knowledge. If you hear overhead sounds, and it's just because I'm at Monash Health at the moment. I've just finished doing a ward round, so hopefully it's not too distracting, and hopefully you understand. And if there's any questions, please don't hesitate to ask me. And I should say, although I'm theoretically a joint head of the myeloma service at Monash, it's really Michael Lowe who's actually been running it and doing an amazing job. And you'll hear from him later on. So I'm a bit like an elder statesman, if you want to put it that way. I've gone all grey. So, sorry. See, also the other thing is my skill sets are terrible. Anyway, so I wanted to start off because given the fact in the last year we've lived in incredibly interesting times, that I think it's actually, and we think as a collective, that this has actually impacted upon the presentation of our patients, often presenting later. And we've actually looked at our own cohort as well. And I just wanted to really start off with this, and a case that hopefully will exemplify this. This is a gentleman that I managed back in January at the Alfred while I was on ward service, an 84-year-old gentleman who presented with months upon months of back pain. And this is on a past history of multiple, what we would say comorbidities, heart disease, type 2 diabetes, hypertension, etc. He was initially admitted under general medicine and was found to be hypercalcemic and was treated with a drug called permethrinate, which is one of the bisphosphonates, and it actually is used often to reduce the calcium. He didn't have any anemia or renal impairment, and he was under general medicine for 3 weeks for pain management, and he had all these bony lesions, and the etiology, that is, the cause of that, was unknown. So he had numerous investigations, and those investigations demonstrated features which would be very suggestive of an underlying what we call plasma cell dyscrasia or myeloma. And one of the things that we actually, what they ended up doing was biopsying one of the lesions. They biopsied the right 7th rib lesion, and basically the biopsy demonstrated that this patient had sheets of plasma cells. These are the cells that basically result in the disease. And we do special tests which demonstrated that all the bone was effaced, in other words, replaced by these cells, which basically was consistent with the diagnosis of myeloma. What was very interesting about this patient was that this patient did not have an abnormal serum protein electrophoresis nor an abnormal kappa lambda ratio. In fact, this patient was a non-secretory myeloma. And in 2021, that's incredibly unusual and uncommon, and often represents less than 1% of all presentations of myeloma. And it probably resulted in the delay of this patient's diagnosis. Unfortunately, despite therapies and commencement on bortezomib-based therapy, he had significant back pain. Trying to control his back pain with various medications resulted in significant confusion, delirium, and decompensation. And at about 10 to 14 days later, a decision was made for palliation, and the patient was made comfortable. It was discussed with the family, and we felt that was the best way forward. So that was just an example, and I just wanted to share with you some of our own data to demonstrate that in the during pre-COVID and post-COVID, and really one of the things that I wanted to highlight was that basically patients that basically presented with a much higher paraprotein during COVID than pre-COVID, so 23 versus 36. And basically 35% of patients required either radiotherapy or surgery to their bone lesions, as opposed to only 13%. So you can see that there was clearly patients who were presenting later, and whether or not that was because of fear of coming to hospital, or whether or not that was because of obviously the delirium that occurs in a pandemic. I think this really exemplifies, and we've seen this not only for myeloma, but obviously for a number of other conditions that we actually manage as hematologists. And I'm sure the oncologists and various other specialties, namely cardiologists, neurologists, etc., have also seen much later presentations and really end-stage disease. So this brings me to what is multiple myeloma. And this is a slide that some of you may have seen who've looked at my talk, but I think this is a really lovely slide, because what it really demonstrates is that really myeloma is basically derived from these cells called plasma cells. I asked, what are plasma cells? Plasma cells are the cells in our bone marrow that produce antibody. These are really factories that produce antibodies to things that we've been exposed to, and they generate immunity, and they protect us from the subsequent infection. So the whole premise of vaccination is to ultimately generate a long-lived plasma cell, which will generate an antibody response that will allow us to be able to combat any microbial or any viral or any fungal infection. So what the difference is that, unfortunately, in patients with myeloma, is that they actually get a proliferation. That is, these plasma cells become many, they're abnormal, and they're dysregulated. In other words, they basically start to replace the normal bone marrow, and they produce one type of protein, because they're all daughters of the parent plasma cell, and they generate a monoclonal protein. Monoclonal just means derived from one parent cell line, and it generates all these proteins, which is exactly the same. And this is what we call the monoclonal protein, the M protein, the M spike. and the paraprotein. So this is what when you go to your doctor and when they say, oh, what was the paraprotein? This is what we talk about. And of course, you would have heard of things called light chains. And the light chains are basically part of that paraprotein, which is a smaller component. And often we can measure those separately. And both of those things are very complementary in our assessment of disease status and also disease response once patients have actually commenced therapy. And one of so what happens, what's the big deal, one may ask when you produce a lot of these proteins? Well, the issue is not necessarily also the proteins. The issue is what impact the proliferation of these abnormal cells has on the bone marrow, the bone, the production of these antibodies, and also what impact it has on other systems. And the impact that it often has is firstly anemia, because basically it's an inflammatory disease and it results in the red blood cell production being reduced. It can result in bone destruction. The bones basically, because it alters the normal balance between bone forming and bone destroying cells. And in myeloma, most of the time this results in bone destruction, and people may present with what we call lytic lesions, and in extreme circumstances can present with fractures. Fractures of vertebrae are the most common, but often that can present with fractures of the long bones, that is the long arm bone or the long leg bones, and this is quite obviously debilitating and quite catastrophic, especially when it presents with spinal cord compression. As a result of that, patients can also have high calcium levels, and this can impact on patients' presentation. They can be confused. They can actually have constipation. They actually feel generally quite miserable. And of course, it can affect our kidney function test as well. And the kidney failure that we see in myeloma is as a result of many, many, many different reasons. And actually, there are about 9 or 10 different reasons why patients can go into renal failure because of myeloma. So most of us that love myeloma actually have a pretty good understanding of the kidney disease that's actually associated with it. And as a result of you producing one type of antibody, you've got to remember this abnormal plasma cell is a bully, and it replaces the normal plasma cells. So your normal antibody production is reduced, you get immune suppression, and you're at increased risk of infection. So that's really, in a nutshell, what myeloma actually is. This is just an example of a patient, and this is Sarah Newbury, and this was around about 1839, and Sarah was basically the first reported patient with myeloma. And this actually demonstrates what myeloma can do. And can you imagine at that point in time in the history of humanity, that presentation was quite confronting. And at autopsy, there was this amorphous tissue that replaced normal bone marrow. And people didn't know exactly what was going on, obviously, but they just realized that this disease actually just replaces normal fat spaces and normal marrow. So I put this up just to sort of like remind us that there are amazing people in history that actually have allowed us to form and have a better understanding of myeloma. Henry Bence-Jones, some of you would know that we often speak about Bence-Jones proteinuria. So Henry Bence-Jones was a Scottish chemist, and he was quite famous for actually understanding and precipitating out the light chains from the urine. And the second man with an impressive beard was Otto Kahler. He was from Hungary originally, I think, and then subsequently was in Vienna. And the disease was actually called Kahler's disease for some time. And he had a series of patients with myeloma. And of course, the last gentleman, Jan Waldenstrom, who has the disease actually named after him, Waldenstrom's macroglobulinemia. He identified really how to measure and the protein spikes that actually occurred in myeloma. So they're three very important people in the history and understanding of myeloma. So this is a timeline, and just to really give you an idea that really from early on, when we basically had some understanding that this was an abnormal disease, there were all sorts of remedies that were actually attempted: rhubarb, orange peel, steel, quinine, etc. In the 40s, urethane was actually used, and it was actually thought that actually urethane was actually a modality that actually resulted in therapeutic in therapy. Urethane is not a therapy for myeloma. Urethane does not do anything apart from poison the host. And it was only in the 50s where really the mustard derivative melphalan was actually first described. And later on in the in the late 50s, early 60s, where corticosteroids, that is prednisolone, dexamethasone, etc., were discovered, and these were really the backbone of therapy for myeloma. It wasn't until really the 90s where high-dose chemotherapy was given and salvage autologous stem cell transplant was administered that we actually had some way forward. And as you're all well aware, it wasn't until the turn of the century that basically thalidomide, that is the first of the immunomodulatory drugs, and subsequently the proteasome inhibitors, came onto the market. And it wasn't until 2012 when PBS, the Pharmaceutical Benefits Scheme, approved bortezomib as first line. And most recently last year, as you're probably all aware, and I'm sure Michael will speak more of it, we've actually got bortezomib, lenalidomide up front for all patients with myeloma, potentially, if it's appropriate to administer it. So we've come some way. The other thing is to note that despite all the advances, myeloma is still an incurable disease. Myeloma basically is preceded by this condition called MGUS, or monoclonal gammopathy of undetermined significance, or smoldering, and which often will proceed to myeloma. It often has an asymptomatic phase, or smoldering as sometimes it's called, and then subsequently to active disease, where we would treat, it goes into a remission. Now, this remission may be a PR, a VGPR, or a complete remission, and then it relapses, and so on and so forth. And we often have first, second, third line therapies. So this is also important to note. How common is it? It's around about, it's, pleasingly, it's not really that common, but it is common enough that we see around about 2,000 new cases in Australia each year. So that's not insignificant. It constitutes 10% of all blood cancers, 1% of all cancers. So it actually is, and it's relatively more frequent in males as opposed to females. And as you probably are all aware, it's a disease of older patients. That is, the median age is around about the 70-year mark, where 2/3 of patients are over the age of 70 and 1/3 are less than the age of 70. But as Michael and I could attest to, we have seen patients in their 20s and 30s who do actually have myeloma. There are all these criteria for diagnosing, and I don't expect or don't want you to necessarily know or understand them, but just to say that as blood doctors, we often are guided by these criteria. And these are often just criteria which have been, they're historical. Often a lot of them are actually a little bit outdated with respect to how we approach it. But a lot of it is really just for us to be guided as to whether or not how intense, how we should be looking at it, and how we should investigate it. And in about 2014, there was this updated criteria for the diagnosis of myeloma. And I think that was really important, because one of the things that really came out of that data was that myeloma doesn't necessarily need to be symptomatic for us to actually treat it. And some of you would be aware that there's an entity called ultra high risk smoldering myeloma, or asymptomatic myeloma. And we have various definitions that will allow us to say, okay, despite the fact that this patient is well, there are no features, that is the traditional features that we see: hypercalcemia, renal impairment, anemia, bone disease. These people have an 80% chance of progression within 2 years. Therefore, if it is appropriate, and following discussion with the patient and their family and loved ones, we would recommend that they would be treated. So this is a discussion that we have, and there are times when we wouldn't treat. If the patient is older and the patient will say, look, George, I'm happy, we can watch and wait closely, but it is one of those things that they will most likely require treatment within 2 years. So it's a really important thing to be able to at least guide and educate our patients, because it's predictive of the nature of the disease. And of course, we know now that patients that actually even fulfill high risk asymptomatic myeloma, we know that the likelihood of progression is likely within 5 years. Again, there's no data that we should actually be doing it off trial, but if there is a clinical trial available, we often would recommend that our patients would enroll on that trial if appropriate. So The thing is costs, yeah. I mean, this is the one thing I know. It's all these medicines cost a fair bit of money. Even thalidomide, a drug that probably many of you would be aware was a drug that was used in the 1950s for morning sickness, and unfortunately had devastating outcomes to the unborn child. Is still at a few years ago, $10,000 a year. It's not an insignificant amount of money. And of course, the more novel agents are upwards of 50, 80, $100,000. So you can imagine when you combine bortezomib and lenalidomide, this is a fair bit of money, especially in a nation like Australia, where all this money and all these medications are PBS funded. So that's why it's really important to have stringent criteria and really ensure that only a finite number of people can actually prescribe these medications. But you're going to say, well, it costs so much, why can't we just use other medicines? Well, what we do know is that when I started off as a registrar, and I was very fortunate to see sort of the transition from what we call non-novel agents to the novel agents, what we found was that the people that achieved the CR without adding a novel agent was less than 5%. In contrast, when you actually combine RVD, for example, is what we're using in many patients in 2021. We're seeing approximately 40%. So you can see that there's been the depth of response has actually is actually important. And you say, well, who cares? It's incredibly important because we know depth of response correlates to increase of progression-free survival. That really correlates to better quality of life for our patients. And we all probably are in agreement that if we can get patients into a deeper response, it really actually is where we should be going and how we should be moving forward on this. So there are all these guidelines. Obviously, as a doctor, we need to take a good history and examine our patients, which has been challenging during these COVID times, but we try to ensure that we see our patients, especially our new patients. We do various blood counts. We look at protein electrophoresis. We do urine with our light chains. And of course, all patients will undergo a bone marrow aspirate trophine, and they will often undergo what we call skeletal survey. In 2021, we often do not do x-rays. We will do a low dose CT. We often will do a PET scan, and we may or may not do an MRI. So that all depends on the availability of these modalities in the center that you're actually being managed at. This is just to demonstrate these cells here are what are the plasma cells. These are the cells, the myeloma cells. This big guy here is a megakaryocyte, which is basically the mum and dad of platelets, which are also important cells. And this is just to demonstrate when we do a bone marrow, this is what we call a trophine, and we stain it with a special dye called CD138. And the only cells that are positive for CD138 in the bone marrow are plasma cells. And it really allows us and helps us to enumerate, that is to count how many plasma cells are actually in a bone marrow. You may ask me, what's the normal number of plasma cells in a bone marrow? It's usually less than 5%. To be frank with you, it's usually 1 to 2%. In patients with myeloma, it's more than 10%. And in fact, with people present with myeloma, they often have 50, 60, 70, 80% of plasma cells within their bone marrow. So the overall principles, as I alluded to, myeloma is still an incurable disease. I'm hoping by the time I retire that I can say myeloma is a curable disease. And that's obviously what we should be aiming for. We treat patients when they have end organ damage or symptoms. That's true to a large extent, but as I alluded to previously, we will treat patients who we know will progress within 2 to 5 years. The deeper the response to therapy, the better patients do. This is actually a paradigm that is true for many blood disorders. Combination therapies are better than single agents, absolutely. The issue here is obviously tolerability. It's okay to say that we can use all these combinations, but how will our patients tolerate them in the real world? How can they be delivered? It's no point giving patients multiple novel agents and they fall apart. It's really important to ensure that you are able to do this. And this is one of the hardest things to be able to do. And there's no absolute right answer. And there is this difference between how we manage transplant eligible and transplant ineligible patients. So just briefly, just to demonstrate that regardless of the era that we're actually looking at, despite the fact that the number of patients that survive in the more recent era, we certainly know that there's a fall off in overall survival. In other words, regardless of all the therapies that we're using, the, the curve never flattens out. The curve actually continues to decline. And regardless of whether or not they've been transplanted or not, or exposed to a new drug or not. So that's one of the things that we need to try to address, to understand how we potentially are able to generate I guess, a myeloma-free state and be able to generate a flat curve that will phenocopy what we would see in the normal population. So I guess one of the things, and this is a slide that, it's a lot, some of these slides are obviously for Michael, and this one's from another colleague of ours who also is a crazy fan of myeloma, obviously much crazier than us, Pasquale, who basically really, I think, illustrates quite nicely that disease actually, it starts off quite, you can have a primary mutation, and then you can have something that looks quite angry. And I always, when I try and tell patients and describe them about disease, I always use the example of being in a room with a domestic cat. I'm fairly happy being in a room with a domestic cat because I guess it's sitting in the corner. It's not bothering me too much. Occasionally, they can be a bit demanding, but I'll be able to manage that. However, imagine sitting in a room with a tiger. I'm not entirely sure, even if it was sitting in the corner, how comfortable I would feel. And this is basically the progression and the evolution of disease. And that's exactly what happens in myeloma. There's nothing that anyone has done to deserve to get myeloma. Myeloma is an event that occurs because our B cells, which is basically the cell that myeloma is, the plasma cells derive from, lives an incredibly risky life to protect us. And these things make mistakes. And as we get older, these mistakes increase. And if we all live long enough, we would probably all have a monoclonal gammopathy of undetermined significance, that is an MGUS. And if we looked at the population over the age of 80, we would find that possibly 8 to 12% of the patients probably have a small monoclonal protein. And if we live to 120, I'm sure that would be more like 40 to 50%. So just to give you an idea that this is just an event that happens as we get older. Okay, so it's really important. The definition really is a fairly straightforward definition that we've had. This was really defined by the Mayo Group many years ago out of Minneapolis. And there's 10% plasma cells is really what we would arbitrarily state as being the cutoff for what myeloma is. A paraprotein of 30 grams a litre, or if there's any evidence of end organ dysfunction. And MGUS is really the opposite of that. We start treatment, as I alluded to, when people have symptoms. But of course, I also touch on the fact we start treatment when we know that people are at an increased risk of progressing. And it's basically the pros and cons of treatment. Okay? It's a really important thing for us to actually understand. I also talked about high-risk MGUS and smoldering myeloma. The normal approach has been that we watch and wait. But as we go on, as we have therapies that we know are able to manage disease, we will find that we will be probably utilizing therapies earlier on rather than waiting until our patients are symptomatic. There are various trials in smoldering myeloma, and we know that the observation group, the progression-free survival in the observation group is actually inferior to the one in the treatment group. But that's to be expected. I guess what we need to know is that these treatment modalities in the real world are safe, are deliverable, and don't evoke adverse effects. So these are the really important things that we need to consider as clinicians, and also the cost benefit, not only, and also quality of life issues, which are often incredibly difficult to enumerate and quantify. So one of the things that I know I'm very passionate about is depth of response. So as I alluded to at the start, a lot of these response criteria have been quite antiquated. And in fact, what we used to say to patients, oh, you've achieved a complete remission. And complete remission is this arbitrary term of less than 5% plasma cells. We had a negative paraprotein by immunofixation and normalization of light chains. The issue is that this we know is not enough. This, in many instances, is as good as a VGPR. It actually is not very different. What we do know is that if we need to achieve a very, very deep response, and there are various modalities by which we actually can look at that. And these graphs really just demonstrate that if you're able to achieve a CR that basically is, at a very, very low level, your progression-free survival and overall survival increase. These are all complete remissions. But complete remission, when you have basically a level that's MRD negative, that is minimal residual disease negative, is very, very different to complete remission with MRD positivity. And these tests can be done either by a special molecular test, that is DNA testing, or by testing by flow cytometry. And there are some centers in Australia that actually do this as a routine to look at this. Now, we don't at the moment utilize this to basically manage or, I guess, make a decision about what to do with our patients. But a lot of the trials at the moment are utilizing this as an endpoint and really defining it as a progression-free survival endpoint. And I suspect what we will be doing in 10 years' time is utilizing this as a marker and enabling us to make a decision as to whether or not we need to give more therapy to our patients or whether or not we can stop therapy. And as I alluded to, there are different ways we can test this MRD. And, as I said, we can do various DNA testings. That's polymerase chain reaction of the heavy chain of the plasma cells, and sequencing of the antibody part of the DNA. And of course, by flow cytometry. And to give you an idea, you're going to say, well, how many cells can you detect? With these tests, we can detect one abnormal cell per 100,000 to 1 million. So that is the depth of response we can actually have, which is really, really important. And we know that if you can get a level of less than 1 into 10 to the 5, that is, there is less than one abnormal cell per 100,000 cells counted, we know that the French group have looked at this data, and we know that the patients have a progression-free survival of about 4 years. And that's really, really important. So they're the things that we need to start thinking about how we can get more of our patients into this MRD negativity, because that ultimately is what we're all trying to do with all these therapies. So regardless of what method you use, you achieve MRD negativity, you do better. Okay, it's really the take-home message. And I just very briefly will say that we know that when you use combination therapies get greater depth of response. And a lot of these are really being borne out from numerous clinical trials over the last 10 years, where we know combination therapies, especially from the North American trials and the large European consortia, have actually demonstrated this quite eloquently. And the combination of novel agents, and especially novel agents with newer agents as well, such as daratumumab and other monoclonal antibodies. And of course, well, I'm sure Michael will discuss the utility of newer technologies such as the bispecific antibodies and the CAR T cell technology. And I think one of the hardest things for all of us is, where do we sequence these? Do we try to use the best things up front, or do we use it in the first relapse? And these are the things that really, I guess, are topics for discussion and debates. And often there have been many debates and disagreements amongst, eminent individuals in this area. So what to treat with? Well, really, these are the backbone therapies that most of you would be aware of. And we basically, and often, as at the moment, most of our new patients off trial will receive an immunomodulatory drug together with a proteasome inhibitor. And that's usually the standard of care in Australia in 2021 for most patients who could tolerate it. And we know that combination therapy is better. This is RD versus RVD. This is the SWOG data, the Southwest Oncology Group, and demonstrated quite nicely when you add Velcade to the backbone of lenalidomide and dexamethasone in non-transplant eligible patients, they do better. Okay, but still, you can see that the progression-free survival still is not flattened. So this is really important. We need to do better. I mean, there's no doubt. We're making incremental improvements, but we need to be better and try and flatten that. And I guess why would they work better? Well, they work better because they act in different ways. So if you, and in fact, it is the paradigm that we use for other diseases. So in lymphoma, for example, we use combinatorial chemotherapy together with antibodies. So why wouldn't we do the same thing for myeloma? And that is the premise of what we actually do. So for example, lenalidomide can affect the nucleus, bortezomib can affect the endoplasmic reticulum, which is really the factory of where the protein's being made, and the antibodies affect basically can bind to the outside of the plasma cell and target it for cell destruction. So this is, what combination? Well, the combination's really, as I alluded to, a proteasome inhibitor with lenalidomide, with an imidazole, which is a lenalidomide. And of course, lastly, I just wanted to touch briefly on the dichotomy. You're all aware that basically, if patients are transplant eligible, we would transplant them. Age is not necessarily a barrier. In other words, of course, usually the data really had been up to 65. I just saw a recent publication of Peter Mack. I think they've suggested that they're in their cohort up to 75. 65 to 75 is a grey zone, and it really is on the individual. In other words, you choose the patient that would tolerate it, because it's about tolerating the autologous stem cell transplant. That's the most important thing. Even in 2021, stem cell transplantation is the standard of care, even in the era of combination therapy with novel agents. An autograft is basically us collecting your stem cells before we deliver to you high-dose chemotherapy and then rescuing you with those stem cells, because that high-dose chemotherapy, which is usually melphalan, is toxic to stem cells. So we would need to take out your stem cells first before we give you the melphalan, and subsequently 24 hours later, we infuse those stem cells, and those stem cells decide to go back to the bone marrow and make new blood cells. And that is the premise. And really, the transplant itself is a rescue for your blood cells. It's not the treatment per se. The treatment is really delivering high-dose chemotherapy, in this instance, usually a high dose of the alkylating agent called melphalan. And we know that in the determination trial that was published in 2018 by the French and North American groups, they demonstrated quite nicely, even in the presence basically of the combination of novel agents, the transplantation trumped and this combination. What was interesting is that in patients who achieved MRD negativity prior to transplant, these patients did as well as patients who were transplanted. In other words, you probably do have a subset of patients who probably do not derive any more benefit if you transplanted them at that point in time. The problem is that the study was not powered for that. In other words, that was not the question that was asked of the study. Therefore, we cannot definitively state that, and we probably cannot definitively, I guess, cannot definitively suggest that as a treatment option for our patients. So that's really basically what I've already said. And the last thing I wanted to say is that, as you're well aware, we in Australia, in the last year, we've actually been able to get maintenance therapy. Maintenance therapy is with lenalidomide, and we know that for most patients, lenalidomide will increase the depth of response, and it has resulted, when they looked at did the meta-analysis for 3 studies that looked at this, in improved overall survival. So definitely there is utility for maintenance therapy for most patients with measurable disease, if they tolerate it, of course. This is one of the things that's actually easier said than done. And that's exactly as we said, patients who are fit enough should have an autograft. And len maintenance, it is funded in Australia, and it should be offered. And that's just the monitoring thing. So all of us monitor our patients. I'm usually 2 to 3 months, depending on paraprotein. To be honest with you, with our myelomas, we're a little bit more protective, and we would say to you that we usually see our myelomas every four weeks if they're on therapy. If they're not on therapy, usually it's every 2 to 3 months. And that's really just a summary. I think my last slide is questions. So I'll stop there. I talk too much. I'm sorry.
Thanks so much, George. It's awesome. So we've got a couple of questions.
Yep.
The first one is from Karen from New South Wales. So Karen has been through all PBS options and a doctor's considering a clinical trial. She finds this understandably quite scary, especially being off treatment at the moment. She's told a break from treatment will help her. Is this true?
Without knowing the particulars of the case, it's an incredibly interesting question. Look, help her with respect to psychologically help her, yes. If a patient needs therapy, they need therapy. I'm assuming the clinical trial is, given the fact she's exhausted all therapeutic options through PBS, a clinical trial sounds like a very appropriate thing. Obviously, clinical trials can be incredibly onerous. One thing about clinical trials is that there often is a washout phase. In other words, 2 to 4 weeks is often a standard that basically patients need to be off therapy in order for them to be eligible to enroll on a clinical trial. The wording of this will be good for you, I'm not entirely sure where that comes from. And without, as I said, knowing the particulars, it definitely is good to be off therapy from a psychological point of view, from having your life back for some time. And I think what I would like to say is that to the patient is that the doctors will be keeping a very close eye on you, because I know we have a number of patients in that position, whether it's at Monash, whether it's at the Alfred, whether it's in myeloma, or whether it's in lymphoma or any other disorders, because we know sometimes disease can be a grumbling disease. It can grow very slowly, and that's okay. We're happy with that. But we just don't want to avoid disease just exploding and becoming incredibly aggressive, because that's when we need to do something. So I guess I would like the patient to feel, safe and assured that her doctors are doing the right thing and looking out for her disease. And I guess what they're trying to say to us, don't stress too much that you're not on therapy, because we want to bridge you to a clinical trial that will enable us for you to get access to therapy that you would not normally have access to through the pharmaceutical benefit scheme. I hope I answered the question. Okay.
Great, thank you. We've got two more questions. The next one is from Eleanor. Can you please speak about the genomic testing as a tool for developing targeted drug treatment?
Yeah, look.
A great question.
No, it's a great question. Genomic testing. So there's a lot of work done around trying to understand each patient's individual disease. Now, myeloma, although we group disease as one disease, it's not one disease, clearly not. We know that 80% of our patients will respond incredibly well to the modalities that we have available to us. But we also know that about 10 to 20% will do incredibly poorly. And about 10% of patients will die within 2 years, regardless of what we do. They have very aggressive disease. So we do know that there are some genetic or molecular abnormalities or fish abnormalities that we actually see that are often more sensitive to certain medications than others. And a good example of that is a translocation called 1114, which overexpresses a protein called cyclin D1, which is very important for the progression of the cell cycle. In other words, as cells divide. This is not a very common abnormality in myeloma, but we do see it. And what was very interesting is when they use the drug venetoclax, which is basically used for other diseases, in particular in CLL, where it's really changed the landscape in that disease, we found that single agent venetoclax worked exquisitely well for these patients with 1114 translocations, but really didn't really do anything for the other patients that didn't have 1114 as a single agent. It did work quite nicely when combined with proteasome inhibitor, but often toxicities with that were actually quite significant, and obviously you needed to choose the patient and then really keep a close eye on infective complications. So genomics can guide us. The problem is that one of the things that we really would love to know is, does everybody need combination therapy up front? It's one of the things that we're trying to understand, is that there are some people, whether or not you give them just Lendex, they'll do as well if you give them Lendex versus the, bortezomib, lenalidomide, and dexamethasone, and really trying to understand that profile. And often targeted therapies, a lot of myelomas have mutations in this pathway called the RAS-RAF pathway. And these drugs have not actually demonstrated really any efficacy in this disease group. So it's not as straightforward. And myeloma is an incredibly complex disease. It's not like, unfortunately, like a CML, where we know there's BCR-ABL and you can actually target it with a drug that seems to control the disease for long periods of time. In myeloma, the disease is multifactorial. And it's probably not only the disease, not only the plasma cell, it's the environment. The environment is very, very important. One of the things that, Michael and Pasquale and myself and a lot of other people that try to do research in this disease is that you can't kill myeloma in the patient. You can't grow it outside the patient. So clearly the environment plays such an important role, the bone marrow environment, that niche. When a disease, and most of the cell lines that are available to us are what we call cell lines which have either, through patients that have gone multiple rounds of different therapies and have progressed, or have got rapidly progressive disease. And this does not reflect normal myeloma. This is disease that we often see, what we call extramedullary disease. And this actually almost behaves like a lymphoma with really attitude of a myeloma. So it actually can be incredibly difficult. So to cut a long story short, yes, there's a lot of work being done to understand the genomic landscape of myeloma. We understand a lot of it. The problem is that there's no specific targeted therapies at this point in time. We do know that, as Michael, I'm sure, will speak about at the moment, there's a lot of emphasis on looking at, particular proteins that are expressed on the myeloma, and a lot of the CAR T and the BiTEs are actually against a protein called BCMA. But again, and when we look at it all together and we look at what separates a normal plasma cell and an abnormal plasma cell, there are various targets that come out. And for example, Michael's PhD, and he'll speak about this, was really looking at part of that and trying to identify that. And he'll speak to the fact that it seems there are the usual suspects, and BCMA seems to be one of these. But again, it's not as clear. It's not as simple as just saying, oh yeah, we've got this mutation, we'll just use drug A that we've actually got. It may work. The question is predicting who will respond to it. And that's what we don't have at this point in time, because a lot of these drugs generate toxicity for our patients, and exposing them to our patients with a low likelihood of effect is actually probably not the way forward. So we need to understand and have predictors of who will or will not respond before exposing our patients. I mean, imagine if we knew straight away what drugs our patients would respond to and not respond to. I mean, why would I use lenalidomide if I knew it wasn't going to do anything to a patient? I wouldn't use it. I mean, it's not without its own adverse effects. So this is really one of the hardest things in disease, is trying to say who will respond, how will they respond, and what is the adverse profile. So they're the things that we need to do. And it's not as simple as saying, oh, the disease has got mutation A and mutation B. But yes, there are some that are predictive. Thank you. I think that's it. Yeah.
Thanks, George. One last question from Wilhelmina from the Northern Territory. Is it okay for myeloma patients to have the COVID vaccine?
Yes. Yes, we encourage all our patients to be vaccinated. All patients, all hematology patients. I mean, we're not sure whether you're on active therapy, how you will respond. In other words, what type of immune response you'll generate. But my thinking, and I'm a very simple human, is that my thinking is that even if you generated 10% or 20% immunity, it's better than no percent immunity. And that's the whole premise of what we're trying to do, is generate some immunity against a virus, which we know for our patients, of course, elderly patients, patients with comorbidities, and which often includes a large proportion of our myeloma patients to start off with, in addition to having myeloma, is very important. And the other question should be which vaccine, and whichever one you get offered is basically the vaccine that you will take. We ourselves will be offered, when we get vaccinated, that's exactly what happens. It's just basically a vaccination And I think with the current recommendation is that absolutely we would strongly recommend and encourage all Australians, but in particularly our patients, to get vaccinated.
George, we'll let you get back to your ward round and for your wonderful presentation today.
It's my pleasure. I finished my ward round. I was very good. So I'm going to listen to my colleague talk.
Okay, we really appreciate the time you've given us and explaining the concepts today of myeloma so well.
Thank you.
We'll now go and have a short break before our next speaker comes to the stage. Please let's just go and have a stretch and grab a drink, and we'll see you in 5 minutes. Welcome back, everybody. Our next speaker is Dr. Michael Lowe. Michael is a haematologist at Monash Health. He works there as both a physician and a pathologist, as well as serving as the Director of Clinical Training and Myeloma Lead. Michael is a fellow of both the Royal Australian College of Physicians and the Royal College of Pathologists of Australasia. Michael undertook his undergraduate studies at Melbourne University before completing his PhD studies at the Walter and Eliza Hall Institute of Medical Research, for which he was awarded the Gus Nozzle Award from the National Health and Medical Research Council of Australia. Michael continues to undertake research as a principal investigator on a number of myeloma trials at Monash Health. Michael has published in numerous international journals, including Blood, British Journal of Haematology, Cell Reports, and the Cochrane Library of Systematic Reviews. Thank you, Michael, for joining us this morning.
Thank you, EJ. Thank you for the invitation. So my talk's going to be about an update from ASH 2020 from late last year. But I will touch on a few things that George has already touched on. Just to try and make sure that if you didn't see George's great talk and you don't have an opportunity to look at it before this, that you can follow what we're going through. So just very briefly, these are my disclosures. None of this affects what I'm going to talk about today, but for transparency, that is my disclosures. All right, so before we talk about the American side of haematology and what came out of there, I think we just need to talk very briefly and just reinforce what George has already talked about. So we're just going to talk about two things. We're going to talk about what's currently or readily available therapies in myeloma in Australia, and then what has up until now been the broad idea of ideal therapies in myeloma, which George very nicely summarized in his presentation as well. So let's talk about the first one. So these are the treatments that are available for myeloma. And you can see here that there are 4 broad drugs which are readily available up until sort of late last year. There's corticosteroids or glucocorticoids, which include dexamethasone and prednisolone, chemotherapy, for some reason, which I still can never quite work out why, alkylating agents such as melphalan cyclophosphamide seem to be the most active. The thalidomide analogues, which we also call the IMiDs or immunomodulatory agents, which in Australia comprises thalidomide, lenalidomide, and pomalidomide, and then the proteasome inhibitors that you can see, bortezomib and carfilzomib. One of the things that I have problems with when I talk to patients or other doctors about myeloma therapies, I find that just giving them a list like this can be very confusing and not necessarily that helpful. So when I talk to patients or junior doctors about how we treat myeloma, I try and give an analogy which hopefully helps them conceptualize what we're trying to do. So if we think about what a myeloma cell is, which is a malignant plasma cell, which George talked about, essentially, if we think about that in very simplistic terms, the plasma cell or myeloma cell is a factory. What a myeloma cell does is it produces antibodies, and in this case, an abnormal antibody called a paraprotein, which you can do blood tests to monitor, which George once again talked about. So if we go back to our analogy about a factory and we think of something that we don't want, something that's completely useless, let's say, for example, I don't know, Richmond number plates, okay? So no one would ever want that. So let's think about how we target plasma cells or the factory for these unwanted product. And if we look inside, on the left-hand side, you've got an electron microscopy picture of a plasma cell. And what you can see here, I'm not sure if you can see my pointer, but you can see the black thing is it's a nucleus, which is where all the DNA is contained. And then around it, you've got all the factory for antibodies or protein, which is made up of Golgi and these funny looking lines here, which is called an endoplasmic reticulum, which is essentially the biological equivalent of a factory line. So if we look at this and we look on the right-hand side and we conceptualize it, we think about the critical components to a factory. And this is just a cartoon that I've pulled off the internet, which I always find amusing. So if we think about this factory and think about how we might stop a factory from producing something, well, the first thing you could do is you could target the production line. And in the simplistic way, that's what chemotherapy and glucocorticoids or steroids do. So in a biological sense, or in a myeloma sense, the factory line is the ability to produce an antibody, and you can target that by giving a patient chemotherapy, which blocks the ability to produce proteins, which antibody is one of. And so we use alkylating agents, as I said, like melphalan and cyclophosphamide. Similarly, you can destroy that sort of production line by using corticosteroids, which really stop the ability to produce proteins. And we use a number of different proteins. You might use dexamethasone. Some people use prednisolone. You might see that in some. And that's probably the most easy to conceptualize about how we might target a myeloma cell. But there are other things that we can target. So you could look at the office. So where are the blueprints for what you're trying to be made kept, or how does the factory know what it's meant to be producing? And so we can target the office. And in a biological sense, that's really targeting what we call transcription, which is the ability for that nucleus where the DNA of a cell is kept, and its ability to then translate that into a protein which can be produced, such as an antibody. So this is what we're talking about. So we're all made up of 46 chromosomes. All our cells are made up of 46 chromosomes, and that DNA really doesn't change too much unless you get a mutation in it from when you're born. So when you're a single cell from a sperm and an egg to who we are now. But obviously, our different cells look different. So we have skin, we have hair, we have eyes, we have different eye color, we have different eyelashes, hair, all that stuff. And the way that our body tells what proteins or how we can make it is something undergoing this process called transcription and then translation. And if you want to modify that blueprint for that factory, you change that transcription, which is sort of shown here in a schematic on the bottom left-hand corner. And really, I mean, this shows how long I've been in the field, but when I first started my PhD, this was like just earth-shattering kind of research that it's really become sort of kind of expected knowledge, I guess, in our field, that we discovered that the IMiDs, or the thalidomide analogs, such as lenalidomide or pomalidomide, what they do and the way that we think that they mainly function is they stop this transcription by changing these two transcription factors called IKZF1 and IKZF3, which stand for Icaros and Aeolus, named after the Greek gods, Icaros being the Greek god that flew too close to the sun whilst wearing wax wings and fell out of the sky. But these transcription factors are absolutely critical for myeloma survival, and by affecting the way that the myeloma cells produce these transcription factors, you essentially destroy the blueprints, and therefore the myeloma cell can no longer produce protein, and as effect of that, it will die. So that was really exciting. So you can target the production line, you can target the office, and then the third way that we've often targeted myeloma is that we target the waste disposal. And in a biological sense, what that means is stopping the breakdown of proteins that weren't made the way that you wanted it to be made. And we do that by targeting something called the proteasome. The proteasome is essentially the waste disposal of a cell. And what it does is, like I said, it just basically breaks down misfolded proteins, and so it can be recycled. And what happens essentially is you block this pathway, you just get a buildup of rubbish, and then the whole factory sort of stops working. And that is how proteasomes work. So the next thing that I would like to talk about before we talk about the newer therapies is just discuss a concept which George very kindly kind of introduced, which is what's the best way of treating myeloma, and what's the ideal therapy up until sort of now. And this is, you can see that George and I obviously work very closely together because the slides are very similar, if not exactly the same. But essentially, these are studies, and the absolute words don't mean that much, but I'll just guide you through it. So these are called Kaplan-Meier survival curves. And on the left-hand side, you have a percentage of patients who entered the trial who are alive, and if it's overall survival are alive, or if it's progression-free survival are still in remission from that therapy. And then on the y-axis, x-axis, you got the months or time since the start of that trial. And what you can see here is that essentially, if you're not familiar with scientific knowledge or scientific publications, essentially what you want is you want the curves to be as high as possible. So this curve here is better than this curve here. The blue curve on the right-hand side is better than the red curve. And what you can see here is that it's hard to see on this. It's a bit blurry on my screen, so I imagine it's blurry on yours, but I'll just guide you through it. But essentially, the bottom line here is bortezomib, which is one of our proteasome inhibitors. And if you add dexamethasone to the bortezomib, you can see you get an improvement in survival. So combinational therapy is better. On this one, once again, it's a bit blurry, and I do apologize for that. But what you've got on the red is lenalidomide with dexamethasone. So this is an IMiD with dexamethasone. And then on the blue line, you've got the addition of bortezomib, also known as Velcade, to lenalidomide and dexamethasone, RVD versus RD. You can see that the survival curves improve. And this concept of using combinational therapies when tolerated, obviously, is one that we've really stuck by until, we still stick by in terms of our optimal therapies moving forward. Sorry, just trying to. And this continues to be borne out. So this is a study that was published actually at ASH in 2019. And so if you can tolerate it, so this is adding daratumumab, or which we're going to talk a bit more about later on, but daratumumab to a combinational therapy of Velcade or bortezomib, thalidomide, and dexamethasone. And once again, just looking at these Kaplan-Meier curves on the right-hand side, that if you have more things and it's tolerated, that patients do better and they survive longer without disease. So there is this ongoing thought that if you add more things to the therapy, that patients will do better, especially if it's tolerated. So why would combinations be better? Well, the way that I conceptualize and I talk to my patients is, imagine that this is a maze and there are lots of different ways out. And that what this is essentially for a cancer cell is that getting out of the maze is survival. So if you use one therapy, you block one exit, but if you use that therapy for long enough, the cancer cell will find another exit and will get out. But if you keep blocking exits, you get better responses. And the ultimate aim would obviously be to block every single exit so that there is no escape for that cancer cell and you kill off all cancer cells. Now, at this stage, unfortunately, because myeloma is an incurable cancer, we cannot say that we're at a stage where we feel like we have blocked all the exits, but we are certainly working on it to try and get to that stage where there is no escape for the myeloma and that we can talk about a cure with our patients. And not being overly optimistic, but I think it's not that far away. I try and keep a positive mind, but we do think that a lot of the technology and the research being done potentially might have the potential for a cure in the near future, but obviously we'll have to wait and see. So how else can you target myeloma? So if we go back to our analogy of a factory, and our factory making something completely useless like Richmond target number plates, there's one really glaring obvious thing that we haven't talked about, and that is sort of the bricks and mortar. So we've talked about what's inside the factory, but we haven't talked about the structure, the foundation and the walls. And, from a biological sense, couldn't we just get a giant wrecking ball or strap some dynamite to that factory and just kill it off using that? And the way that you do that in a biological sense is you target the cell surface. So we've talked a lot about what's inside the cell, but not what's on the cell surface. And a lot of what we're going to talk about now, or pretty much everything we're going to talk about from now on, all the new therapies have been targeted at the cell surface, or what we would consider from a factory perspective to be the bricks and mortar. All right, so we're going to just talk about a few really exciting abstracts that were presented at ASH, and there are 4 that I'm going to talk about. I'm not going to overload you with everything. You could spend the rest of the year watching, presentations from ASH, and you could spend the rest of your life probably just reading one ASH booklet and just trying to read them all. But we've just tried to really pick up some highlights that I think are demonstrating the way that we treat myeloma is progressing and how it will change moving forward in the next couple of years. So the first thing I want to talk about is a surface protein called CD38, this drug, daratumumab, is the most well-known, but there's a couple of other ones, including something called isatuximab. And essentially, these are antibodies that target a surface protein called CD38. CD38 is very highly expressed on plasma cells, but it's also expressed on some other immune cells like T cells and also some other hematopoietic cells such as red blood cells. And this drug is very effective at binding CD38. Now, the phase 1 study was published in the New England Journal of Medicine, which is equivalent sort of like Time magazine, or trying to think of equivalent in, it's the medical journal sort of premier, so the premier medical journal. This was published, 2016. So it's been sort of 5 years since this drug first hit the market. And what you can see is that if you just use daratumumab as a single agent, really, even at optimal doses, which is 16 milligrams per kilogram, here on the left-hand side, you see that only about 36% of people will have a response. And this is shown on the right-hand side in terms of a waterfall plot. We're not going to talk about that. We're just going to focus on this left-hand side. Only about a third of patients have a response, which, when we look at these patients that we're talking about, these are patients that really didn't have any other options in terms of therapy back at that stage. 1/3 of them having a response is not bad, but I think if you look at that and you think, well, 2/3 aren't going to have a response, that's not what we would consider an ideal, salvage therapy. So a lot of work was then done as, could you combine daratumumab with other regimens? Sorry, my app is just disconnected, so I'll just hopefully be able to go. And so that has been recently published. So this is in 2016. So the other one must have been before that. In this paper, also published in NEJM, which is called the CASTOR trial, which is combining daratumumab with bortezomib and dexamethasone. And I'm just going to show you some once again, Kaplan-Meier curves. And what you can see here, that if you add daratumumab to bortezomib and dexamethasone, that you improve the progression-free survival of patients. So these patients who got daratumumab did better than patients that did not. And overall, it was seen as a really positive result. And this led to PBS listing daratumumab in this combination of daratumumab, bortezomib, and dexamethasone on the PBS, and led to quite a lot of news stories. I think if anyone's following the news late last year, you can see in December last year this came out, and there's a very well-known hematologist from Melbourne in the picture. And I think a lot of people were very excited by the fact that it had been listed for use in Australia for all patients in that setting. But I would like to draw your attention to one thing which I think is a big problem, which is that daratumumab in its current iteration on PBS is currently only approved for patients who met essentially the criteria on this trial, which is people who'd only received one line of therapy and only in combination with this combination of bortezomib and dexamethasone. And I think personally, as a clinician who's always trying to find new therapies for my patients, I think that that's a bit of limited in scope, and I think that there is room to improve on that indication. I'm not trying to make any comment about the political nature of listing drugs on PBS, but I think that there is opportunity to improve the listing for daratumumab, which I think is a really important drug moving forward. So there was this study published or presented at ASH, which is called the Apollo study, and I'll just showing you the slide here so you can see the authors on that. But essentially, to guide you through this is combining daratumumab with a different regimen. This is using it in conjunction with pomalidomide and dexamethasone. Pomalidomide and dexamethasone is a combination used in patients who have had multiple myeloma in Australia, usually after around 3 lines of therapy. You can see here that the key eligibility criteria is that they had to have at least 1 prior line and been exposed to a proteasome inhibitor such as bortezomib and to lenalidomide. So, this is the group that would essentially we would be looking at pomalidomide, dexamethasone in Australia. We might use it further down the track, but essentially this was a randomization. So 50% of patients got daratumumab added to their pomalidomide and dexamethasone, and 50% just got what we would consider standard of care, which is pomalidomide and dexamethasone. If you look at this, once again, a Kaplan-Meier curve, what this showed is that that the addition of daratumumab to pomalidomide and dexamethasone led to improved progression-free survival in patients compared to those who just got pomalidomide and dexamethasone alone. And you can see that that is quite a large difference between the curves. The other interesting thing about this paper is that that the daratumumab was given via subcutaneous route, so that's an injection in the tummy as opposed to in a vein in your arm. And I don't know if anyone's had daratumumab IV in Australia. It's only approved intravenously. This is exciting because that's a much more deliverable regimen. So giving someone an injection in the tummy like a diabetic injection is much less painful for a patient and requires a lot less time in hospital than giving it intravenously. So it's demonstrated that the subcut version, which has been published previously, is also an effective regimen in patients with myeloma. So they showed further data. On the left-hand side, they're showing that the addition of daratumumab to pomalidomide lead to higher rates of responses. So this is 69% versus about 46%. So, an extra 20% of patients responded. And then George has talked about the minimal or measurable residual disease negativity, that they had more people having deeper responses as well. So by all scientific parameters, the addition of daratumumab to pomalidomide dexamethasone improved the regimen and improved the patient outcomes. So what I concluded from this is that daratumumab subcut is effective in combinations. The addition of daratumumab to pomalidomide and dexamethasone leads to deeper response and improved progression-free survival. And as a clinician and for my patients, ideally, we would love to have daratumumab available in more combinations and at different stages of the patient's disease than what is currently available on PBS. And I think that that's something as a myeloma community that we will continue to lobby the pharmaceutical benefit scheme and the Australian government to try and approve that so that more patients can get access to this therapy at different stages. And I think this paper, whilst it's not really, I guess, what we consider earth-shattering, it does give us the basis to go with data and say that this is the evidence to suggest that we should be allowing people to use this combination or daratumumab in other combinations further down the line. And hopefully the interest groups will listen to that. All right. The last bit of my talk, and there's three abstracts here I'm going to talk about, is targeting a new molecule, which is really quite new. And I did a lot of research, as George alluded to, in my PhD, called BCMA, which stands for B cell maturation antigen. So this was actually published, BCMA as a target was really published two years ago in ASH, and there's been a real kind of explosion of ways of targeting BCMA. But essentially what it is, it's another receptor which is almost exclusively found only in plasma cells, both normal, but particularly in myeloma plasma cells, so malignant plasma cells in multiple myeloma. It's a receptor for the TNF receptor superfamily. It's, the actual family itself doesn't matter. I think what's important for people listening in is that it's a receptor that the myeloma cells, at least theoretically, use to keep themselves alive. And there have been a number of therapies that have been used to try and target BCMA. The first one being the DREAM studies, which is using a drug called belantamab, which is in trials in a number of centres in Australia. It was called GSK 2857916, which is just a drug name, but it's now been given a trade name of belantamab. And a number of people in Australia will be either offered or may even be on the DREAM trials, which is essentially looking at the role of belantamab in myeloma. I'm just going to show you the DREAM-1 study, which essentially showed that in patients who had really no other therapies available to them, and understanding this was quite a long time ago, that the overall response rate was around 60%, which was pretty exciting. Unfortunately, that hasn't kept being borne out as single agent as they've done more and more studies. And it seems to be that that exposure to daratumumab or CD38 monoclonal antibodies might reduce your response to this belantamab, this new BCMA targeting antibody. And a lot of the DREAM trials are now very similar to CD38, looking at combining it with novel therapies. But I actually am not going to talk about belantamab because I feel like that's old news and there's a lot of trials. But I think there are two new ways of targeting BCMA that I do want to spend just a little bit of time just talking to you about, because I think they're really exciting. So the first one are the BiTE antibodies, and these are also known as bispecific T-cell engager antibodies. And what they do is that they have an antibody which will bind to your protein of interest, so in this case, BCMA. But it has a second antibody attached to it, which will bind to a cell which you want to bring into contact with that. And in this case, or the majority of them, they're going to be T cells. So for those of you that aren't that familiar with T cells, what they do is they kill cells when they're marked with antibody. So not only do you mark the cell for death by T cells, but you actually bring sort of the execution or the firing squad into direct contact with the cell so that it will kill off the cell that you want it to do. And this technology has been revolutionary in other cancers, such as B acute lymphoblastic leukemia, for where there is blinatumomab being a therapy against CD19, which is approved in Australia and is widely available in Australia. But they're moving this into the space for myeloma and using BCMA, or B cell maturation antigen, as the target. So this is a paper published, presented at ASH last year. These are only phase 1, so we're talking very low numbers of patients. And this is, if you're interested, this is the trade name that they've given it, teclistamab. And essentially it's a bispecific antibody which brings the myeloma cell in conjunction with the T cell. So hopefully the T cell will kill the myeloma cell. All right. So what I really wanted to show you is just this curve on the left-hand side. So because it's a phase 1, this is what we call a dose escalation. So it's essentially the first in human study. They didn't know what dose would be tolerated by people, so they start with a low dose and they build it up as if people don't have significant toxicity to it. So you can see that the lower doses were started off here, and if they don't have toxicity, they build it up until what they feel is the optimal dose. And at this stage, they're thinking it's about 1,500 micrograms per kilogram. You can see that, you know, there are the number of patients under here, and the most people were treated with what they consider the ideal dose. What you can also see is that there appears to be a dose correlation with the response rate. So these are the percentage of people treated with that had a response to this therapy. So at the lower doses, only about 46% or half the patients responded. But at the optimal dose, we're getting up around 3/4 of patients having a response to this. And that's really exciting because you've got to understand that this is a single agent. So this was used as a single agent. And if you compare it to, say, daratumumab, which had a 1/3 response, or belantamab with its 60% response, this is looking even more promising. We're talking about 3/4 of patients having a response to this therapy, which is really exciting. And, 55% having what we call a very good partial response, which is what we would consider a very, a really good clinical response to that therapy. The one thing that I will say about this is that the delivery of BiTE antibodies has been difficult in all spaces because it's a 24-hour infusion. So blinatumomab, which is used in BALL, is given as a 24-hour infusion. So patients sort of come in, they get hooked up to a machine, and they take the machine home, and they have to keep it running through the whole day. And that's a real difficulty, particularly in people in remote areas where they might not have all the material to do it. So this study here, which is the AMG 701 study, which is another BiTE, which was also presented, I think is also really exciting because the key component of this BiTE, and I'm not going to tell you too much about it, is that it's a once weekly. So they've modified this BiTE and it's given just once weekly. And I think that's a real game changer. And that's going to make it much easier to deliver to our patients, rather than them having to go home and stay on a continuous infusion. And that's why I wanted to draw your attention to this paper. And I know that this product is available in Australia on clinical trials, and there are a number of centres with this trial open. And once again, all I want you to look at is this right-hand side, which is the overall response rate in what we consider the optimal dose. And you can see that with this therapy, we're getting up around 80 to 85% response rates, which is really quite exciting. Now, I do want to point out to you with only 6 patients treated on this, so it's not a huge number of people, but the preliminary results is really exciting and is suggestive that this therapy is really effective in patients as a single agent. All right, the second therapy that I want to talk about is the CAR T cells, which I think a lot of people who are listening in on this would be aware of, but I'm just going to go through the CAR T cell and what it is. So essentially what CAR T cells is they take sort of the BiTE T cells and they take it the BiTE antigen antibodies, and they take it one step further. So it's sort of like, can you be more ridiculous in the way that you target this? Once again, this technology is really being revolutionized, or the technology has really evolved through the B acute lymphoblastic leukemia space, where they use CD19 CARs, and has shown just remarkable responses in a proportion of patients with relapse disease. But the theory is, what they do is they take a patient, they collect T cells. So if any of you have been through an autograft, you know that they collect stem cells from you, but instead of taking stem cells, they actually collect the T cells. They take those cells, they put them in a petri dish for conceptualization. They grow them. So T cells are quite easy to grow in a dish. And then they modify them using viruses and newer technology to get them to specifically target an antigen. So in this picture, it's targeting CD19, but in the studies that I'm going to talk about, we're going to talk about they modify it to specifically target BCMA. And then they infuse these cells back in to the patient to see whether those T cells will reproduce and kill off the cancer. Well, kill off anything expressing that marker. So in this case, this was CD19, but in our myeloma patients, we're going to be talking about all the plasma cells which express BCMA. So I just want to talk specifically about this study because the Cartitude compound is actually open in Australia. So the Cartitude compound is available on study in Australia at selected sites. And so some of you may be offered this trial. And this trial itself is not open, but there are further ones down the line which uses this compound. And so I thought this was really, really exciting. Essentially, what they're showing here is that these patients really had very little other options available. So 85% of patients were triple class refractory. Almost half of them had exposure to every known standard of therapy and were not responsive to therapy, and they really had no other options available but these CAR T cells. And this is what's really exciting. So once again, just looking on the left-hand side, the overall response rates in this is 96%, which is exceptional. And really, we haven't seen any single therapy have this higher response rate, at all, ever really in the myeloma space. So this is really, really exciting. Now, if you're watching this, you'll be like, I want to get on CAR. This is the most exciting thing. And I do agree. I think it's one of the most exciting developments that we've had in this space, potentially forever. But I do just want to dampen, your excitement about this just a little bit. So CAR T cell therapy is not risk-free. Before we go into that, you can see that they followed these patients for a long period of time. Everyone got CAR T cells. You can see that the responses were quite durable. So some of these patients were having responses over 12 months, which is very exciting. And progression-free survival was also quite durable as well for the people that did have a response, which is the majority of patients. But this is not a risk-free procedure. So unfortunately, by injecting back in these T cells, you can get a very severe side effect. And you can see here that I think it's up around sort of like 80% of patients will have some form of this syndrome called cytokine release syndrome. And the way that I would describe it to patients is that when the cancer dies, when the T cell kills the myeloma, it releases all these toxins, which are, like in a medical term, they're called cytokines. And that releases a very inflammatory response and makes you feel very well. And it can be so severe that patients can die from it. And unfortunately, there was a patient that died from it in this trial of grade 5 toxicity. It's not, the severe end is not that common, but you can see that this is not a risk-free procedure. A large proportion of people will need to be hospitalized and or will need some form of intensive therapy to support them through this. So whilst we're very excited by the CAR T cells, we do need to just put a damper on and say it's not a risk-free procedure. And there is some more things that we need to talk about. So we also know that they can have something called neurotoxicity. So this is toxicity within their brain. I'm not going to go through this in a huge amount of details, but what I'm trying to paint the picture is that, yes, it's very exciting, but it does come with a trade-off of toxicity. And, we're still waiting to see further information about it. The last thing I'm going to show you is I try to collate all the CAR T cells. So there were 3 sessions on CAR T cells. There's a lot of information on this, but I tried to collate sort of all of them, and some of them look better than others. So the CARTITUDE, which I just showed you, is probably the most exciting because it has the highest response rates. But I just wanted to point out also just a dampener on the excitement on this and just how few patients have been treated with this. So at this, you can see that the number of patients treated is not that high. Okay, like the largest number is around about 97, which is the one that I just showed you, but a lot of them only had sort of 20 to 30 patients treated on. So, this is not, widely spread. It's very intense. It's only offered at certain centers. Similarly, there is quite a variation in the response rates depending on which compound you get. So some compounds look better than others, and each company essentially has its own compound, and most universities have their own compound, and we're still yet to really know which one is the best compound at this point in time. And the last thing I wanted to show you was just how short the follow-up is. So some of these trials have had up to about 18 months, but that's not long. And a lot of these were just looking at a few months of therapy. So we don't know how durable these responses are for a lot of the patients. So even though this is incredibly exciting, and it may turn out to be, the treatment of choice moving forward for relapsed refractory myeloma, we just need to just put a dampener on it and just make sure that we do the scientific work and make sure it is as good as what it initially looks like at this point in time. So this is sort of my summary slide. So how are we targeting myeloma? Well, we've talked about this, but a lot of the new research is on the surface proteins, which you can see down here. What I would just wanted to say to the wider community is there's lots of research being performed in myeloma. At the moment, most of the new work is being focused on marking the surface of myeloma cells, and we can do this by antibodies alone, antibodies bound to chemotherapy, BiTEs, and CAR T cells. But I think at this point in time, we still don't know what the best combination is. And the other thing is, with these newer technologies, particularly CAR T cells and BiTEs, where exactly we should be inserting them into our treatment paradigm remains to be seen. You don't, if there's toxicity, we don't have to make a lot of people sick. If they end up in intensive care or potentially even die, that may not be the optimal choice early in therapy if there are alternate therapies moving forward, like our standard of care, which we know can be delivered to the majority of patients. And with that, I'll stop, and I'm happy to take any questions, and just thank you all for listening.
Thanks so much. That's great. So we've got a couple of questions for you. The first one is from Paul from Victoria. I have always sought to eat healthy, organic food as much as possible. From my limited knowledge, a cancer such as pancreatic cancer is principally caused by 3 known health issues. Is there any research on the causes of leukemia generally and specifically multiple myeloma?
Yeah, so there is a lot of work being done to try and understand why some people get it. Unfortunately, we don't have a simple answer for you. What we know is that there are certain risk factors for developing multiple myeloma. And so there's probably something associated with that leads to the myeloma developing. So we know that being male is a higher risk factor. We know that being Afro-American, I'm not sure if that's a politically correct term, but being of Afro-American descent is higher risk factors, and being of older age is a higher risk factor. We also, there's a lot of work being done about the role of radiation and other chemotherapy agents, and that's really unclear. The most recent data that I've seen is that exposure to radiation doesn't increase your risk of getting MGUS, which is the prelude to myeloma, but does increase your risk of converting from MGUS to myeloma. So there's a lot of research being done. But we don't have a definitive answer as to why some people get it and some people don't. And unfortunately, what we often say to our patients is it's just really bad luck. It's not something you've done. And I just wanted to touch on something that I think Paul touched on. I think a lot of people focus on the protein, and I've had a lot of people ask me, well, because there's an abnormal protein produced by myeloma, should that mean that I should eat less protein? And I think one of the things that I really say to my patients, it's not that you have too much protein. So it's not something that you've eaten and you're eating too much protein and that's why you've got myeloma. It's actually that your body's producing an abnormal protein. And so we don't recommend eating like low protein diets or anything like that. We do recommend eating healthy diets, but it's not that you eat too much protein. It's more that your body just produces an abnormal protein. And I think that's a really important thing that I often get with my patients when we're talking to them about myeloma.
what would be the best daily dose of lenalidomide and dexamethasone to take as a maintenance therapy after 6 months of VRD and going into remission?
So that's a really interesting question. And so we don't really know is the short answer. So firstly, I guess it depends on whether you had a stem cell transplant or not after VRD. If you had a stem cell transplant, the PBS listing for lenalidomide is actually slightly different for people who are just continuing on for lenalidomide and dexamethasone maintenance after VRD. It's actually only approved as single agent, although the government obviously would never know if we continued dexamethasone in our patients if you had a transplant. And it's actually given, for those of you that take lenalidomide as maintenance, you'll know that you take it for 21 days. If you're having it as a therapy, with dexamethasone, you take it for 21 days out of 28. But for maintenance therapy post stem cell transplant, you actually take it continuously. So you just take it, and it's approved at 10 or 15 milligrams. The reason that there's a choice there is because there are about 6 maintenance trials, and they all use slightly different doses, and they all showed effectiveness, but there wasn't one that was clearly more effective than the other. Now, the question is, if you don't have a transplant, what dose should you be on? Well, essentially what we would generally say is the maximum dose that you can tolerate. So if you're having side effects, we usually drop the dose. The other thing that we often look at is after around about 6 months, if patients are in very deep remission, we do discuss with them about potentially reducing their dexamethasone or even stopping it, because we know there are a lot of the long-term side effects from our therapy comes from the dexamethasone. And so some patients will just stay on single agent lenalidomide and actually stop the dexamethasone. But that would be something that you would need to talk to your clinician about and discuss, whether it's worthwhile continuing the dexamethasone or whether you look to try and wean that or even stop it, depending on how things are going. But that sort of depends a bit on the state of your disease, how deep a remission you've had, and how you're tolerating it, essentially.
Thank you, Michael. So we've just got a final comment, actually. It's not a question, but it's from Lorraine in New South Wales. She says that she doesn't have a question, but she's very interested in hearing all the other questions that were asked. And she's been living with myeloma for 25 years. A rare event, I think, and also open for new information. At present, she says she's on thalidomide and dexamethasone with a paraprotein of 1. She's so happy very happy with all the comments and all the questions that have been asked. And she'd just like to give hope to other patients that myeloma can be trodden on in the future. So thank you very much, Lorraine. And thank you, Michael, for bringing all this great information back to the myeloma community. It was extremely relevant and interesting to hear. This event would not be possible without the support of you, the myeloma community. Laura, Rachel, and I would like to thank Steve Roach, our CEO, Hayley Beer, and Nella Coombe, our managers, and additionally our team at head office who have supported us in making this day possible. Additionally, thank you to Darren and the team at CVP. Without their expertise and experience, we've not been able to broadcast this seminar to you. Please remember to complete the feedback form and help us improve our seminars in the future. National Myeloma Month will be held in May. The online seminars will be run on Saturday the 1st of May, Saturday the 15th of May, and Saturday the 29th of May. Stay tuned for the details of local events to be held in your area on Saturday the 22nd of May. Myeloma Australia has a telephone support line for patients, carers, and anyone affected by myeloma. It is manned by a specialist myeloma nurse Monday to Friday, 9 to 5, Australian Eastern Standard Time. Additionally, we have our resources that are available. If you would like any resources, please email or call our head office. These resources can be found on our website and downloaded. Our support nurses run support groups throughout Australia. If you're interested in joining a group, please call head office or complete the form on our website. We have lots of new support groups around Australia this year, so please check our website for further information, as there may be one in your area. Thank you again for all tuning in and joining us, and we look forward to seeing you again in May.